Module 4, Care of the Normal Newborn. The neonatal resuscitation program is the current standard of care for resuscitation of the newborn immediately after birth. It was developed and it's maintained by the American Heart Association and the American Academy of Pediatrics. The RN is responsible for resuscitation, but the LPN has to be able to initiate resuscitation if it's required and assist throughout the resuscitation efforts. That first 6 to 12 hours after birth is the critical transition period. The newborn undergoes rapid transition immediately after birth and requires close observation of the cardiac and respiratory function. We do complete that nursing examination within the first few hours of life, that first couple of hours. We need to get babies started on breastfeeding or bottle feeding. They're going to get different medications. Parental bonding is really important, and safety of the newborn is of utmost importance. This shows the fetal circulation and the respiratory transition, the different things that have to happen during that first few minutes of life. Before delivery, it's important to ensure that adequate supplies are present for full resuscitation in the delivery room and that all of the equipment is working the right way. So you may have a, making sure suction is working, making sure that your lights are working on all of your equipment, etc. Conduct the necessary assessment and provide necessary care to the newborn immediately after birth. And if that infant does not respond appropriately, you need to take steps to correct that situation. It's very important to help the infant maintain thermoregulation. We need to prevent them from becoming overly cold or overly hot. So that means we dry this wet newborn immediately. It also provides stimulation of the baby and helps encourage them to breathe and cough and cry. We put a cap on their head to help prevent heat loss from their head, because remember that head is very large in proportion to the rest of their body. We use that thermoneutral environment to help maintain their temperature at a level that's not too hot or too cold. So they're usually placed in a warmer, set at a certain temperature. But kangaroo care or skin-to-skin care helps maintain that newborn's temperature and promotes bonding. That's basically, as soon as baby's delivered, pull mom's gown down, put baby right there on her chest, and then start putting blankets over the top of them. We need to avoid hypothermia or hyperthermia because either one can result in hypoglycemia, hypotension, or dehydration. Preventing the newborn from hypoglycemia is the best treatment. So we encourage frequent and regular feedings. We need to get that heel stick done to check their blood glucose level with a bedside glucometer and report any glucose levels that are below 50 milligrams per deciliter. There might be some pre-authorized orders regarding how to address low glucose levels in the newborn. So make sure that you're following your facility's policies. Now, if that newborn cannot or will not eat, we may need to do gavage feedings or even give some IV glucose. We also prevent infection. That ophthalmia neonatorum is a severe eye infection because of a sexually transmitted infection like gonorrhea or chlamydia that the infant is exposed to during the passage through the birth canal. We try to give that medication within the first hour after delivery. These can be 1% silver nitrate, 0.5% erythromycin, or 1% tetracycline, and it's an ointment that we put in the baby's eyes. We also take care of that umbilical cord stump. This requires careful hand washing and strict aseptic technique. We might use antiseptic solutions such as a triple dye or bacitracin ointment or povidone iodine initially to help coat the cord, but often we just clean it with isopropyl alcohol. Regardless, follow your facility's policies. These babies are at risk for hemorrhage because of their immature clotting mechanism. So within the first hour of birth, we're giving 0.5 to 1 milligrams of vitamin K IM to help prevent possible bleeding episodes. And making sure that that umbilical cord is well clamped. It can become loose because of large amounts of Wharton jelly in that cord. In other words, it's really thick and really tough, and that can lead to blood loss from the cord. If it's improperly applied or it's defective, that cord clamp could also be a possibility for hemorrhage. And we also need to inspect that umbilical cord for signs of bleeding. We have to prevent misidentification, so this requires making sure that we have some type of identification system before parents are separated. You know, switching babies can lead to heartache and heart-wrenching choices. It requires the utmost care to prevent that from happening. So we use some form of a bracelet system. We prepare 3 to 4 bracelets with identical numbers prior to delivery. We're going to have one placed on mom and possibly on the mom's partner. And then we put 2 on the newborn. We put one on the arm and one on the leg. And usually the facility I worked at, we placed them on opposing arms and legs. So always check the numbers, making sure that they match up when taking a baby out to a mom. It includes mom's name, her hospital number, her healthcare provider, the newborn's date and time of birth, and gender. We do get footprints, but those are going to be more for memento purposes. They're not necessarily for identification purposes when they're in the hospital. It's important to prevent the misidentification of a newborn, and most hospitals will use identification bands. What is it important for you as the nurse to do? Instruct the parents to always check the bands when the newborn is brought to them. So not only should the nurses be checking it, but also the parents. General newborn care is directed at controlling risk and early detection of any potential complications through vigilant observation and data collection. We monitor the cardiac and respiratory status, adequate intake of nutrition. We document every void and passage of meconium. We prevent infection and provide skin care. We prevent abduction, observe the newborn's behavior, watch for any signs of pain, and reinforce information given to mom and other family members. We need to obtain vital signs per facility policy because these babies are at risk for aspiration. We also keep the bulb syringe in the bassinet, and we use it as necessary, and also teach the parents how to use it. Basically, what you do is you compress it and then insert it into the mouth or the nares, and then decompress it, because as you decompress it will suck some of that secretions out. And we also position the newborn on their back for sleep. It helps decrease the risk of sudden infant death syndrome. And it's also recommended by the American Academy of Pediatrics Task Force on Sudden Infant Death Syndrome. With nutritional intake, these newborns need to at least attempt to breastfeed every 2 to 4 hours. Babies may not always breastfeed well, but we do need to attempt. We also need to bottle feed if they're bottle feeding every 3 to 4 hours. And observe mom's technique during the feeding session. If what she's doing is not working, then let's reinforce the teaching as necessary. Make sure that you monitor the newborns for signs of difficulties. If they're having difficulty latching on or sucking, they may have an issue being tongue-tied, or the frenulum is preventing free movement of the tongue. We also monitor the number of voids and bowel movements per day, because that helps let us know that they're getting appropriate nutrition. It is essential to practice good infection control because the newborn's immune system is too immature to fight infection. So hand washing, again, mainstay of infection control. But hand sanitizer is acceptable to use between newborns when visible soiling has not occurred on the hands. We do know that infection can start in the womb, so it's really important to review mom's maternal history and the history of her labor and delivery for maternal fever at the time of delivery, premature rupture of membranes, or the maternal presence of that group B strep. Maybe the umbilical cord has become infected. We see redness and edema at the base, or there's purulent drainage noted. We see early signs of sepsis in poor feeding or hypoglycemia, irritability, lethargy, apnea, or an unstable temperature. So to prevent transmission of infection, newborns should have their own stuff. We don't share it from newborn to newborn. We follow the facility policy for cleaning any reusable equipment. We do encourage rooming in and draping a clean blanket across your shoulder before holding the newborn too close to the body. And universal precautions, always. Make sure you wear gloves until the newborn has had its first bath, and then whenever you come in contact with any body fluids. With skin, make sure you get a thorough skin exam. Delay that first bath until the baby's temperature is stable, and give a sponge bath under the radiant warmer. We don't do tub baths until that cord has dried up and fallen off. Make sure that you wash off all traces of blood to help minimize that transmission of infection. But that vernix, remember that white cheesy coating that might be on the baby's skin or in the creases, don't try and scrub that off. We allow that to absorb naturally. Encourage the parents to participate in bathing. They need to learn how to do this. Make sure you check the axillary temperature when finished. If it's within the expected range, then go ahead and dress the newborn. Swaddle them in a blanket and place them in the radiant warmer. Use warm water only to clean the perineal area and buttocks at diaper changes, although we do use the wipes. But no special oils or ointments are necessary on clean, intact newborn skin. We never use talcum powder because of the risk of those respiratory contaminants in the talc. It has been proven to cause cancer. And make sure that you do not cover the cord. That's why newborn diapers have that depression where the umbilical cord goes. If it does not have that depression, then fold the diaper down so it's underneath the umbilical cord. We also need to provide safety, especially safety from abduction. We have to be really vigilant in paying attention to what's going on in and around a nursery. Watch for any suspicious activity because the risk for abduction is a real threat. Inform the parents to ask to see identification before they give their newborn to anyone. So they need to make sure they have a name tag if it's not someone that they are familiar with. Most facilities do have security features to help discourage abductions. And the cooperation of parents is essential to the effectiveness of any security plan. We never leave newborns unattended. Do not remove any identification bands until they go home. In fact, let mom or dad take those off once they get home. Although we usually do clip one of those off to keep for hospital records. Alert the nurse if the ID band falls off or becomes illegible. Never give the newborn to anyone without hospital photograph ID. Know that the nurses that are caring for mom and the baby, and question anyone that doesn't have a proper ID or picture that doesn't match the tag that they're wearing. If mom is suspicious of any person or activity, make sure that they know to alert the nurses. And know when the newborn is supposed to go for a test, the ordering healthcare provider, and how long that procedure is going to last. Things to watch for in the typical infant abductor. These are usually women of childbearing age, and often they may appear to be pregnant. They're compulsive, use manipulation, they lie, they use deception to gain access to the newborn care area. Often they're married or they live with a companion, and they're motivated by a strong desire to have a child or provide their companion with their child. They're familiar with or live in the community. They are usually a visitor to the unit prior to abduction and ask detailed questions about different routines, etc. They often use the fire exit stairwell for their escape. They do plan their abduction ahead of time. They often impersonate a nurse or another healthcare personnel. One consideration is they usually do provide good care to the baby after the abduction. Newborns are going to respond to their environment in often predictable and organized ways if the caregivers anticipate their needs. The psychosocial task of the infant is to develop that sense of trust. When adults meet the newborn's needs, they do this by feeding the child before they become too upset, maybe doing kangaroo care. This provides comfort and also encourages attachment of the parent to the newborn. Swaddling is very comforting and also helps promote sleep in the newborn. And also understand that non-nutritive sucking can also be comforting. In other words, it's sucking without getting any nutrition from it. Yes, babies do have pain, and prolonged untreated pain can cause problems later on. These babies can experience pain and discomfort from any number of routine procedures. So we use other measures to evaluate pain since newborns can't talk. Are they crying, and what kind of cry do they have? Usually a high-pitched cry indicates pain. Sleeplessness, their facial expression, body movements, changes in their heart and respiratory rates, blood pressure or oxygen saturation can also be indicators of pain. It is an ethical responsibility of the nurse to prevent and treat pain. One way to do this, instead of giving analgesics, is put sucrose on a pacifier prior to a procedure. You may have to repeat the sucrose, or we can inject just like a 0.1 ml into their cheek. It does provide analgesia for minor procedures. And when possible, we avoid situations that might be painful or distressing and provide a quiet, soothing environment. As we begin to prepare the newborn for discharge, we need to continue to monitor and promote healthy adaptations to newborn life and monitor for adaptation of moms and significant others. Watch for signs of positive bonding and prevent pain if at all possible. Make sure that we evaluate the parental knowledge and their ability to care for the newborn and fill in those holes where necessary. Each child is different, so we need to be able to answer any questions the parents might have. And again, we always provide written information for review at home. So true or false? One way to tell if a newborn is in pain is by sleeping all the time. This is false. So let's talk about circumcision. This is the surgical removal of the foreskin of the penis, and honestly, it is a source of a lot of debate. The current position of the American Academy of Pediatrics is evaluation of current evidence indicates that the health benefits of newborn male circumcision outweighs the risk. Furthermore, the benefits of newborn male circumcision justify access to this procedure for families who choose it. It is contraindicated in newborns that are still in that transition period. Newborns that are preterm or sick, they have a family history of a bleeding disorder, they receive a diagnosis of a bleeding disorder, they have a congenital genitourinary disorder. Parents need to have enough information that they're able to make informed decisions as to whether to have their child circumcised or not. Religious and cultural values play a large role in decision, and those values have to be respected regardless of what our personal views are. Again, informed consent is necessary if parents decide to have this procedure done. So how do we prepare for it? First of all, we need the necessary equipment. We need that padded circumcision board, and you can see a picture of it in your slide where it allows us to strap the infant's legs down. We can strap their arms down if necessary, but honestly, swaddling is more comforting. Make sure that you follow orders for pain relief. The facility I used to work at, if we knew a circumcision was scheduled, we put an anesthetic ointment or cream on the penis about an hour before the anticipated procedure. We also frequently used the sucrose on a pacifier during the procedure. There's 3 different types of circumcision. We have the Gomco clamp, we have the Plastibell device, and we have the Mogen clamp. Up top, you see pictures in A of the Gomco clamp, where we're completely cutting off the foreskin, and with the Plastabel, where they actually just clip the foreskin, then place a bell and tie a cord around the Plastabel itself, and this will actually cut off circulation to the foreskin, and then it will fall off on its own. It's important to examine the newborn every hour for the first 12 hours after circumcision for bleeding, and apply gentle pressure as needed. We're also making sure that the newborn can void, and we're observing their urine stream if possible. Instruct the parents on how to properly care for uncircumcised or circumcised penis. It's very important to keep it clean, and on the Gomco circumcision, we use petroleum ointment. With the Plastabel, we do not use that. Often these infants will develop a yellow crust where incisions have been made. Do not remove that. That is basically a sign of healing tissue. And make sure that parents know when to call the healthcare provider if they have circumcision difficulties after they go home. We can provide acetaminophen, excuse me, and as I was saying, that anesthetic cream prior to the procedure, sucrose on the pacifier, swaddling their arms, dimming the overhead lights, playing soft music. All of this can assist with pain relief during this procedure. So immunizations. Hepatitis B virus or HBV vaccination is recommended by the Centers for Disease Control for all newborns before they leave the hospital. And this is not dependent on mom's hepatitis B status. Then, this is basically just the first of 3 vaccines, so they need to follow up with that recommended vaccine schedule. The newborn can become a carrier and not show any symptoms. If mom is positive for hepatitis B, that vaccination and 1 dose of the hepatitis B immunoglobulin is given to the newborn within 12 hours after birth. And there's several screenings that are done with the newborn prior to discharge or shortly after discharge, depending on when they do go home. It is vital to screen for potential disorders to help start that preventative therapy early on to help prevent complications. Phenylketonuria or PKU, congenital hypothyroidism, galactosemia, maple syrup urine disease, homocystinuria, biotinidase, sickle cell disease, congenital adrenal hypoplasia, cystic fibrosis. These are some of the things that newborns are screened for, but each state will mandate which screenings are completed. And they can be different from state to state. However, we also do a hearing screening before the infant is discharged home. It is done through an auditory brainstem response that measures how the brain responds to sound through electrodes that we place on the newborn's head. We have otoacoustic emissions that measure sound waves that are produced in the inner ear. And then an abnormal screening would be followed up with more extensive testing. If you do get an abnormal screening, sometimes it's due to the fact that it was done too early after birth. There may still be some fluid in the ear, or maybe there's some vernix in the ear. And if we give it maybe 12 hours or so and try it again, often that can show a positive result. Early diagnosis and treatment of hearing deficit results in better outcomes for the newborn. So some different slides here to just give you a little bit more information. So we need to reinforce information. Parents are given so much information on self-care and newborn care. So we have to give written forms of instruction that they can take home with them and have something to refer to once they get home. Some helpful topics to provide information on include feeding, sleeping, crying, sensory input, and health maintenance. Some hospitals do offer parenting classes and home visitation programs. The facility that I worked at, we engaged in well mom, well baby exams 2 to 3 days after discharge. We would have mom and baby come back in, and it was a chance for mom and baby, or for us to examine the baby and for mom to ask any questions of any potential complications that might be going on. We do return demonstrations and home visits to allow for direct observation of parents' ability to care for the child. We also demonstrate different ways to hold the newborn. We demonstrate how to clear the airway, using that bulb suction device, instructing them not to overuse that bulb suction, and how to care for the bulb itself. They fill it with water and boil it for 10 minutes. That will help disinfect it between uses. Understand that sneezing is a normal response, but yellow or green nasal drainage are signs of illness, and they also need to seek emergency care if the baby turns blue or stops breathing for longer than 20 seconds. They should know or be educated in infant CPR. They need to maintain adequate temperature control, so protect the baby from drafts, and adequately dress the newborn. The way to gauge this is they put on the same number of layers that they have on, in addition to the type of clothing, and one blanket. If the baby seems to be ill, they should check the axillary temperature. If the temp is less than 97.7 or higher than 99.5, they should report that to the healthcare provider. They should also monitor the stool and urine patterns. There should be 6 to 10 wet diapers per day. That's normal after the first day of life. And report if the newborn does not void at all within a 12-hour period. That meconium is going to be passed at first. So initially those stools are going to be dark, greenish, black, and tarry. But then they become lighter green or light green yellow and looser in character. Breastfed babies have that mustard seed appearance. They're softer, less formed, and even have a sweetish odor to them. But the formula-fed babies, those stools are usually more well-formed, a little bit darker in color, and the odor is a little more unpleasant. Understand that when babies strain, it's not necessarily a sign of constipation. What we look at is the stool itself. Is it dry and hard? Or is it really loose and watery? That will tell us, just like with adults, if there's constipation or diarrhea. And parents also need to monitor safety, understanding that newborns learn to move around pretty darn quickly. We should never leave a baby unattended on a high surface, anywhere near water. There should never be plastic bags in cribs. And we don't use pillows for newborns. To differentiate normal from abnormal newborn observations and behaviors, they need to figure out what normal is so they know what abnormal is, such as the skin color. and proper use of car seats. Car seats should be rear facing in the middle of the back seat. That's the safest place if that position is available in a vehicle. So true or false? The nurse does not need to be concerned about providing a new mother who is G3P3 with information concerning caring for her newborn, since this is her third child. That is false. We never assume that mom knows the right way to do things. So now we're ready for the post-test.